So the client we'll be working with is a 59-year-old female named Cynthia, at the time a college professor. She presented herself to the emergency department about 4 hours after experiencing symptoms of rapid heart rate and mild throat tightness and discomfort. Her history included slightly elevated LDL and reduced HDL levels. At the time she walked on a regular basis, was normotensive, did not smoke, was not a diabetic, but was slightly overweight. Now, it should be noted at the time of the cardiac event, she was working 70 to 80 hours per week and attempting to meet several deadlines, suggesting she was suffering with high levels of stress. It was then after confirmed by doctors through ECG testing and serologic markers that this client had actually suffered an acute myocardial infarction. Cynthia has now sought help through our clinic, primarily wanting to deter a secondary cardiac event, but presents with the main complaint, in her words, that my high levels of stress and anxiety right now are making me overeat and then put on weight. In general, she's unhappy with her appearance. Currently, Cynthia does not exercise, nor has she in the past, and appears quite scared to on her own. She is also now retired, suggesting plenty of spare time, but she says that she has no access to a gym in her current living situation. Also, something else to consider are her current medications, which include metoprolol, a beta blocker, which can blunt her heart rate and blood pressure response during exercise, ASA clopidogrel, which is an antiplatelet agent, actually making her prone to excessive bleeding, and simvastatin for improving her cholesterol, which has been linked to excessive muscle pain during exercise, all of which has been taken into consideration for her exercise prescription. So starting on the left with her physical examination collected during the inpatient process, but firstly we see her blood pressure being classified as stage 2 hypertension according to AHA. Now, while she has medication for this, it's still something that needs to be monitored. Her heart rate also reaching max levels as per her age. A BMI of 27 means she sits in the overweight category, and below that we see her ECG results presented with an atrial fibrillation due to the AMI. Moving down, we see troponin, which is simply a protein release when the heart muscle is damaged, and is used as a serologic marker to see if an AMI has occurred, which it has. And finally, we see an EVF of 50%, which is borderline of healthy ranges, but we do know there was a total occlusion at RCA, and the doctors have successfully treated this with a PTCA and full completion of cardiac rehab. Now, for lab info on the top right, we see her blood glucose being within healthy ranges according to norms, and in relation to norms put out by the Oz Institute of Health and Welfare, we see total cholesterol, LDLs, and HDLs being within healthy ranges as well, which can be accredited to her GP's prescription of simvastatin. And finally, for the graded exercise test, this is something we've conducted as Cynthia's has come into the clinic. And it's quite evident that post-cardiac rehab, Cynthia's exercise capacity and cardiorespiratory fitness are quite poor. So looking at a peak METs of 4 to 5 and also a VO2 peak of 28 means in relation to ACSM norms for her sex and age, it is determined as very poor. Now, both these factors will be crucial to improve upon if we are to deter further health complications. And also ECG results below show quite clearly that the PTCA and rehab was successful, and we can now move forward prescribing exercise not under PTCA recommendations. So moving on to goals, we can see that Cynthia's main goal will be to deter a secondary cardiac event, which really isn't going to have a timeline, but will remain a lifelong goal essentially. Limiting her stress levels from factors of her life that she's experienced prior to the event, and now from the stress and anxiety around the event itself. Improvements in this will be better for lowering chances of a secondary cardiac event as well. And this next goal sort of links as well for Cynthia, where she wants to improve her appearance as she's unhappy with the way she looks and believes that her excessive weight gain is due to stress eating, which is certainly possible, but we're also considering that it can be due to a little history of exercise and possibly being sedentary due to her former occupation. Now, again, it's well researched that higher body fat percentages are a common risk for CVD, so this will help to lower her risk and chance of a second event. Now she really enjoys walking and did so regularly prior to the AMI. This is something she'd like to get back to and join her friends. A great goal for not only lowering CVD risk, but improves physical and mental health and well-being. This can be set as a weekly thing or slowly introduced. Now, due to the AMI, she's reported shortness of breath during some more physical ADLs. This in itself is enough to provoke anxiety for Cynthia, so eliminating this will be important again for mental and physical health. Okay, now just quickly for the goals as a practitioner, ultimately limiting CVD risk factors and deterring a cardiac event, improving exercise capacity and cardiorespiratory fitness, which will also limit the chance of a second event. Secondary to that is easing of medications, which can sort of only be confirmed by a GP, lowering stress and anxiety, which will come along with it, improving walking in ADL capacity through exercise, and again, secondary confidence to exercise on their own. Okay, so for some additional outcome measures I'd like to complete, as research shows, resistance training is recommended post-AMI. So starting with a 30-second sit to stand, a little more endurance focus, which will be important for a return to walking, and a 5 RM bench press. High reps have been chosen as this client lacks experience in the gym, and is still a multi-joint movement, which will give me some more information when prescribing exercise. Also a waist circumference, a DEXA would have been good, but I feel this method is much easier to administer and it isn't too invasive where it will put off the client. This test will provide good info in relation to abdominal fat, which is a CVD risk and also correlates well with cholesterol. Also, we've got a 6-minute walk test. As the other graded test was done on a bike, this will be a bit more applicable towards Cynthia's goals. And finally, a perceived stress scale test for Cynthia's stress and anxiety, seeing if it's improving along with exercise, and if not, if she needs to be referred to further health professionals. Before we move forward, all references spoken about will be included at the end of the slides, and all choices of the program will be backed with references in the written program document. So for the first stage of cardiac rehab, this will last 6 weeks as per ACSM recommendations. I've prescribed 10-minute warm-ups and cool-downs with core activation exercises in the warm-up, and main session duration also as per ACSM for AMI patients. Frequency of 2 supervised and 1 home session, making 3 in total, is deemed appropriate for this population. And you'll see in the table on the right, sets, reps, and intensities have all varied based on the nature of the exercise and also dependent on upper or lower body muscle groups. And building on from that, the intensities have been prescribed through RPE as opposed to percent heart rate max. This is also because of her medications blunting the heart rate response and therefore making it unreliable. Again, by ACSM and further references. The research on rest periods for cardiac rehab remains slightly less unknown. However, 1 to 2 minutes have been prescribed, similar to a healthy population. Okay, for the first session here, now beginning with strength exercises completed in supersets of upper and lower body, And then moving into continuous aerobic, meta-analyses by Mazzolini and Caminiti et al. Show that when combining aerobic and resistance training leads to greater outcomes for lowering blood pressure and improving cardiorespiratory fitness, which are going to be the main focus across the program for Cynthia. Whilst HIIT training has also been shown to be highly beneficial for cardiac patients, as this client has had little exercise experience and displayed quite a poor VO2 max in her testing, continuous was deemed safer at this stage of the program. And finally, exercises have remained quite simple for these early weeks, so less learning will be required. The strength exercise have also been targeted towards ADLs and a return to regular walking. Now for the home session in week 1, starting off with the warm-ups and cool-downs targeted for better posture and hip mobility. This can be viewed in the Word document. These have just been implemented due to Cynthia's past profession and current lifestyle being highly sedentary, working to improve on her realm and posture, followed by gluteal resistance work, also key to her returning to her goal of walking with friends, and finishing off with a continuous walk around the neighbourhood at a lower intensity. This will also be something much safer and easier for Cynthia to complete while still challenging her aerobically. Also, Cynthia has no access to a gym and must complete it at home. Equipment has been kept minimal and relatively cheap for Cynthia to purchase. So an unexpected situation occurs where in week 2 and 3, Cynthia doesn't show up or train, and then she shows up in week 4 where she's put on weight and admits she's joined a HIIT class. The way this is dealt with is that we'll use the session to sit down and talk rather than training, and we'll just look to get things back on track for revisiting goals, addressing what she's finding difficult or what she's enjoying, and in educating on the safety precautions of HIIT when not monitored by a health professional. I'm really trying to end on a high note, recapping on some positives and showing her progressions that she's made so far. And as she's just purchased the membership, I won't be telling her to cancel it, but maybe put it on pause for the moment and revisiting this in a couple of weeks. The goal here will be to not put her off from exercise totally. Okay, so progression's now at week 6, the final week. Now considering that Cynthia missed 2 weeks of training, less progressions have actually been made. But you can see the progressions here in the green, and that the calf raise exercise has progressed to unassisted, so less reps have been prescribed. Okay, now like the last session, reps have been increased rather than intensity to build more endurance for her goal, but also as this client has no gym experience, this is an easier transition to high intensities later on. For aerobic, the RPE is increased, however staying within safe ranges as per ACSM. For the home session, reps have increased slightly, with continuous having RPE and duration increasing. Okay, now onto the next stage, the intermediate, which will last 4 to 6 weeks as per successful cardiac rehab recommendations. Also in the Word doc, you'll see the warm-ups have changed to keep it a little more interesting, and warm muscles based around the new exercises. You'll see intensities have increased overall by 5% for resistance at this stage, and exercises have also progressed or changed to keep it interesting or further strengthen the movement, with a sit to stand going to a box goblet. Bench now has feet up, calf raise off the box for greater load, and an overhead press now included, as it's safe to do so at this stage for hypertensive patients, which was avoided previously. However, intensity kept a little lower for this exercise still for safety measures. Finally, the last aerobic component has now moved to a lower intensity HIIT to build up greater cardiorespiratory fitness, and as it's now safer to do so compared to the initial stage. Here in the second supervised session, cables have progressed to dumbbell for the row. The other couple at the bottom kept a bit more functional, targeted towards ADLs and walking. And also the HIIT has changed modalities from ergos to bikes or different machines for endurance work, with working different muscle groups and keeping it interesting. Okay, now gluteal muscles have progressed here or changed focus, again targeted for muscles and movement of walking gait. Now for the continuous intensities and duration have remained unchanged from the last week of the previous stage, but the goal now is to seek harder terrain such as grass, sand, dirt, for example. and look to go up and down hills. Both will be important for concentric and eccentric movements. The aim will be to maintain speed and RP across the entire duration. Okay, so where sets have now increased to 3, reps have dropped to a minimum range for AMI patients. Progressions have been made in the green. Dumbbell overhead just increased reps slightly due to hypertension. HIIT also increased by 5 intervals in total, but has remained at 1 minute's work with 1 minute rest. Okay, now onto the final stage. This phase of cardiac rehab is recommended by ACSM to last for 6 weeks, but is essentially continuous from here to further maintenance and improvement for her condition and comorbidities. Squat to bench has gone to free, barbell to dumbbell bench, and a bent over row now to standing, all harder versions of the previous. Also for resistance exercise have now returned to 3 with 3 sets. This has been shortened as the focus shifts more towards cardiovascular components now for walking goals and further BP improvement. Intensities have increased by 5% from the previous stage and have now reached maximum for the cardiac patient. Now HIIT circuit has been implemented at the end of it, as opposed to one modality with 2.5 minute intervals, still working in a 1-to-1 ratio. This will be the longest Cynthia's had to work at this high of an intensity. Also multiple exercises implemented to keep it interesting. Now in the home session, hip hinges and lateral slides for hip abduction, whilst flexion and extension is worked in the other sessions, and the walk at the end now encouraging a hike even, but looks to incorporate stairs, hills, terrain, and a longer duration and a higher intensity than before. Okay, now all strength progression seen in the green here. For the intervals, these have increased to 4 minutes now for aerobic, for much higher endurance and cardiovascular fitness, with benefits towards other comorbidities, which would likely be seen around this stage, according to research. Again, harder variations of the exercises, and it should also be mentioned that variations won't be progressed until easier versions have met the upper ranges for a cardiac patient in relation to reps. And finally, for the home session, reps reaching a maximum and duration RP at the highest for continuous walking so far. At this point, Cynthia has progressed immensely for her walking goal and will look to continue doing so post the intervention. Thank you.